Ah, the white cataract. When we see this type of cataract, we know that the surgery is likely to be complex. During this case, I'm going to share with you the myriad of decisions that we need to make to successfully and safely treat a complex white cataract. Now let's go get after it. This is a 38-year-old patient seen in our office in early June. She is an otherwise healthy individual without a history of eye issues or eye trauma. She functions without glasses. Her vision in this eye is counting fingers only. Her slit lamp exam, shown here, reveals a white cataract that appears to be tense and under pressure. We can see the anterior capsule, which normally is relatively flat. In this patient, the capsule is bowing forward as if this young lens is swollen. This curved capsule and the white cataract are clues that fixing this cataract will be complex. So we advise the patient that there is the possibility that she will have complications such as an Argentinian flag sign that may require more complex maneuvers and even possibly vitreoretinal surgery to remove the cataract and place a lens implant into her eye. The Argentinian flag sign is a classic and dreaded complication of treating white cataracts. It occurs because the lens inside the capsular bag is under such great pressure that when the capsule is opened, the capsule opening expands in an uncontrolled manner to the outer edge of the lens capsule where the zonules are. And sometimes this uncontrolled capsular opening expands from the anterior capsule past the zonules and around to the posterior capsule. When this complication occurs, then the cataract can fall into the vitreous and then require vitreoretinal surgery as a second stage procedure. For this patient, we have advised her of this potential complication and tell her that we will bring our A game to do our very best to help her cataract surgery go smoothly. She is very nervous about her surgery. We are her third surgical opinion for how to treat her white cataract. So here is her eye in the operating room as we are about to begin her cataract surgery. She has chosen to have a basic monofocal lens. Her eye is numb with eye drop anesthesia using lidocaine. She is awake but under the influence of 10 milligrams of Valium. Next, we want to stain the anterior capsule to optimize the ability to safely visualize the anterior capsule during our capsulorhexis. We then infuse Vision Blue, then wash it out with balanced salt solution or BSS. Next, we give her some viscoelastic. There are many choices for viscoelastic, so we choose Helon 5. We elect to use a 27 gauge needle to puncture the anterior capsule and then aspirate lens material to decompress the pressure inside the lens capsule being caused by this white cataract. So we puncture, then aspirate and move the needle laterally to aspirate as much lens material as we can. Then we fill the anterior chamber with more Helon 5. Okay, now we're ready to get it on. The whole case will go as well as the capsulorhexis goes. So we grasp the edge of the anterior capsule and carefully begin the capsulorhexis. As we are about halfway through, we have some difficulty visualizing the capsulorhexis edge to re-grasp the anterior capsule and continue the capsulorhexis. Because we temporarily lose our grasp of the anterior capsule leaflet, we choose to place additional Helon 5 to flatten the anterior capsule and to help us re-grasp the edge of the capsulorhexis. When we infuse the Helon 5, the Argentinian flag sign occurs and the anterior capsule opening extends to the zonules at 10 o'clock. Now what do? We elect to complete the remainder of the capsulorhexis with a beer can capsulotomy using a 25 gauge cystotome needle to release tension on the anterior capsule edge. Hopefully the anterior capsule extension at 10 o'clock does not extend beyond the zonules. If that occurs, then the lens is going to drop into the vitreous and the case is over. We choose to not perform hydrodissection. This patient is 38 years old and the lens should be pretty soft in this relatively young person. So we begin to phacoemulsify the cataract gently. We find that removing the subincisional cataract is difficult using the phaco handpiece, so we elect to use the I and A handpiece to remove the subincisional cataract. We make every effort to keep the anterior chamber formed and avoid anterior chamber collapse. Anytime we remove an instrument from the eye, we place viscoelastic into the anterior chamber to keep it formed. If the anterior chamber collapses suddenly, then the risk of anterior capsule extension going posteriorly is greater. Ultimately, we are able to successfully remove the cortex and see our eccentric anterior capsule opening. We can see the lens epithelial cells on the posterior surface of the anterior capsule. It's probably not a great idea to leave them there, as the anterior capsule will more likely opacify long term, and that may reduce the vision for this patient in years to come. So we refill the capsular bag with viscoelastic, and then we use the Singer sweep to polish the lens epithelial cells from the posterior surface of the anterior capsule and to remove residual subincisional cortex. Now, where should we place the lens? So I plan optic capture, haptics in the sulcus, and the lens optic inside the capsular bag. But in order to do this, I need to modify the anterior capsular opening. So we fill the bag with Amvisc Plus viscoelastic and use MST micro scissors to cut the anterior capsule from different angles to widen the anterior capsular opening. Then when we zoom in on the anterior capsular rim, we can see little tags in the anterior capsule edge created by the micro scissors. So we then use the MST capsulorhexis forceps to grab these tags and create a smooth edge to the anterior capsule where we originally had converted it to a beer can capsulotomy. Now, ultimately we have a more symmetric and round anterior capsular opening. So we then insert our go-to monofocal lens, the Bausch & Lomb LI61AO, and place the haptics into the sulcus, then push the optic into the capsular bag. We then use IA to remove viscoelastic anterior and posterior to the IOL. Finally, we hydrate our corneal incisions to make sure the eye is watertight. At the end of the case, the IOL is perfectly centered and looks great. We reassure the patient, who was super nervous before surgery, that her surgery was successful. Her post-op day 1 vision is 20/25 with a refraction of -0.75 sphere, yielding 20/20. Her preoperative vision was counting fingers. This case illustrates some key decisions that need to be made with every white cataract. Number 1, the preoperative discussion that the case will likely be more complex than average. This is crucial. Number 2, the surgical tips and tricks to manage and successfully navigate the minefield that is the white cataract. As they say, the perfect plan is always in the planning room. When you get to the battlefield, Murphy shows up and the perfect plan has to be modified because of the chaos that is encountered on the battlefield. Thankfully, we were able to adapt and overcome the issues encountered in removing this white cataract. Thank you for watching. I hope you learned some good tips for how to skin the white cataract. Have a wonderful day.